Hello, I'm Dr. Janu Kumar. Today, I will be sharing a case study on newly diagnosed type 2 diabetes with high baseline HbA1c level. Mr. AB, a 45-year-old with newly diagnosed with type 2 diabetes mellitus, visited the clinic 6 months back with multiple risk factors like obesity, hypertension, and hyperlipidemia. He was initiated on metformin with an advice for lifestyle and diet modification. Recently, he visited as part of his routine checkup. He had done some laboratory workup which showed the following reports: an HbA1c of 8.5 percentage, EGFR of 80 ml per minute per 1.73 meter square, LDL of 80 milligram per deciliter, HDL of 38 milligram per deciliter, and a triglyceride of 200 milligram per deciliter. He was on the following medications: metformin 1 gram twice daily, lisinopril 40 mg once daily, metoprolol ER 100 mg once daily, atorvastatin 40 mg once daily, and aspirin 75 mg once daily. On physical examination, his BMI was 31 kilogram per meter square. He had a blood pressure of 120 by 70 millimeters Hg and a heart rate of 78 beats per minute. Evidence indicates that early intervention and achievement of glycemic control reduces the long-term risk of microvascular and macrovascular complications in type 2 diabetes, as per the UKPDS trial. The UKPDS trial demonstrated a legacy effect of early intensive therapy because the difference in the cardiovascular event rate 10 years post-trial was apparent, even though there was no difference in the HbA1c levels between the intensive and conventional therapy. When metformin was not suitable and empagliflozin or linagliptin is being considered as an alternative first-line therapy, initial combination therapy may be considered to achieve the target more quickly, particularly in patients with high baseline HbA1c level. Early combination therapy in type 2 diabetes makes clinical sense for several reasons. First, a meta-analysis demonstrated that early use of combination therapy significantly increases the likelihood of achieving the glycemic target of HbA1c less than 7% as compared with metformin monotherapy. For patients with HbA1c, which is more than 1.5% above the goal at diagnosis, ADA and EASD guidelines recommend the first-line treatment with a dual combination and an SGLT2 inhibitor as the first post-metformin treatment in patients with established cardiovascular disease, congestive heart failure, or chronic kidney disease. Empagliflozin and linagliptin combination with complementary mechanism and pleiotropic benefits may be suitable option across a range of patients, even including those with established atherosclerotic cardiovascular disease or high risk or established heart failure or chronic kidney disease, due to the tolerability of the combination in addition to the potential benefits of empagliflozin on cardiovascular and renal outcomes, and no increased risk of heart failure with either agent. According to the study, early achievement of HbA1c goal, that is less than 7%, with empa/lina could reach target HbA1c at 12 weeks compared to monotherapies. HbA1c decrements by empa/lina, that is a 25 by 5 milligram dosage, has demonstrated a 1.81% HbA1c reduction at HbA1c baseline, which was more than or equal to 8.5% at the end of 24 weeks in metformin-treated groups. The benefits on glycemic control were maintained at week 52 in metformin-treated groups, and a higher percentage of patients achieving HbA1c levels less than 7% were reported for the combinations. The combination offers a suitable component in strategy to achieve target HbA1c without increased risk of hypoglycemia and weight gain, with an overall improvement in the lipid profile. A reduction in the incidence of genital infections associated with an SGLT2 inhibitor has been reported when a DPP4 inhibitor is added, perhaps because of a better glucose control, although other possible mechanisms remain to be investigated. In summary, empagliflozin-linagliptin combination provides robust HbA1c reduction and a 2 to 4 times higher odds of patients reaching the goal HbA1c compared to individual agents with a low hypoglycemic risk. Thank you.